Good afternoon and welcome to the Schroeder Lecture at Case Western.
Max, wait
Yes.
until everybody's in.
Oh, how do we know?
There's only 24 in. Look at the bottom. We need to get close to 200
Oh, okay.
participants.
Bear with us, participants. We'll start in a moment.
Okay, I think you can go.
Second. Okay, good afternoon, everybody, and welcome to the Schroeder Lecture at the Law Medicine Center at Case Western Reserve University School of Law. My name is Max Melman, and I am the co-director. And with me as co-host is my co-director, Professor Sharona Hoffman. And she and I will be forwarding your questions and comments to our speaker after her talk. It's my pleasure to welcome you to this lecture. The lecture is named for Oliver C. Schroeder, Jr., who joined the faculty of what was then the Western Reserve School of Law in 1948, and in 1953 founded the Law Medicine Center, the first law school program in health law in the country. Please note that CLE credit is available for this session, and at the end, I'll post a slide with more information, and our Director of Academic Centers, Patty Harbold, will be posting the link to the CLE form on chat, I believe. So by the terms of the charter of the Schroeder Lectureship, which was established in Ollie Schroeder's honor when he retired in 1986, the Schroeder Scholar in Residence is selected on the basis of, quote, scholarly distinction and contribution in the arenas of health policy and law. I am delighted to tell you that our 2020-2021 Schroeder Scholar amply fits this, meets these requirements. She is Tammy Boyd, Chief Policy Officer and Senior Counsel for the Black Women's Health Imperative, which was founded as the National Black Women's Health Project at Spelman College in 1983 and became the Black Women's Health Imperative in 2002. As Chief Policy Officer and Senior Counsel, Ms. Boyd leads the organization's strategic policy and government affairs. Ms. Boyd has an MPH degree from Emory University School of Public Health and a Juris Doctor degree from American University Washington College of Law. Following law school, Ms. Boyd was a legislative aide to Representative Benny Thompson, chair of the House Homeland Security Committee. From 1996 to 2004, Ms. Boyd was the legislative director for Congressman John Lewis. She was the senior staffer who drafted the legislation that elevated the Office of Minority Health and Health Disparities at NIH to a center and now an institute. Ms. Boyd also was instrumental in gaining congressional authorization for the National African American Museum. Following her time on the Hill, Ms. Boyd did governmental affairs work for Johnson & Johnson and DaVita, and she was managing partner for TKB Global Strategies, LLC Watts Partners. Ms. Boyd has served as a member of the Corporate Advisory Committee for the Congressional Black Caucus Foundation in Washington and as vice chair of the Congressional Black Caucus Institute's 21st Century Council. Today, Ms. Boyd will speak to us about health equity during the COVID-19 pandemic, legal implications, and the need for policy to affect change. Please, after Ms. Boyd's talk, enter your questions and comments in the Q&A, not in chat, which will not take them from you. So please join me in welcoming Ms. Tammy Boyd.
Thank you. Thank you for that introduction and for inviting me to participate as a speaker of the Oliver C. Schroeder Lecture. And let me share my slides. Okay, can you all see the slides? Okay.
Yes, we can.
So today I'm here to discuss health equity during the COVID-19 pandemic and the need for policy change to address health disparities, particularly as it relates to the rapid transformation and adoption of technology in our healthcare system. COVID-19 crisis is one of equity. Those who were more at risk at the beginning of the crisis have fewer safety nets, less support, and deeper challenges. As you are aware, and the data confirms, there is a disproportionate impact of COVID-19 on vulnerable communities, particularly African American and Hispanic, Black and Brown communities. We must address the wide-ranging implications of this crisis from an equity lens, while also having a deeper understanding of technology implementation during the pandemic. We must place equity at the center of COVID-19 relief and the adoption of long-term digital and technological transformation. In some regards, the expedited adoption of telehealth is an opportunity to address health disparities, but we must do so in a careful and intentional way so as not to further exacerbate the already existing health disparities. We must utilize this opportunity to glean lessons and provide recommendations to policymakers, key health stakeholders, and if we are looking to make permanent some of the changes that have happened during COVID in terms of the telehealth, we must, use this opportunity really to really glean some of those lessons. Let me start with the first slide. I just wanted to give an overview of where we are now. As of this morning, there were 55.7 million cases worldwide with about 1.3 million deaths. The US is 4% of the world's population, yet this morning, we had almost 21% of the world's cases. There are currently over 11.4 million plus cases, and there's an average of 158,265 new cases per day. And this was as of this morning. I mean, these numbers, I was working on this presentation yesterday, the last 2 days, the numbers just, they continue to go up. And so there are now over 250,000 deaths in the United States. We're currently averaging more than 1,000 deaths per day. The number of cases has increased in all 50 states over the last 2 weeks. And more than 76,823 Americans are currently hospitalized with the virus. And so, as we know, when the pandemic first started, there was cases in Seattle, Washington, and we heard of a few in California, but then we really saw the epidemic take off in New York, and it made its way down the East Coast, and then by the spring, summer, it was the South, and now if you look at the headlines now, the recent headlines now, it's really in the Midwest. And so here's just some of the recent headlines around, where the virus is now. And the Midwest has been hit particularly hard. Clinics and hospitals and ICUs are running out of beds. Just last week, we heard that, Illinois was in a 30-day shutdown, which is really a good example of really what's going on in the Midwest. We heard about, people are having to be transported further and longer for non-COVID treatment, often where time is the essence. New restrictions are being put in place. And so specifically for minorities, they've been really hit and disproportionately impacted by COVID. Blacks are 2.6 times more likely to contract COVID, 4.7 times more likely to be hospitalized, 2.1 more times more likely to die. And patients are hospitalized who really have, we call it, underlying causes. We're hearing, like, for example, hypertension, obesity, high blood pressure, cardiovascular issues. I mean, in some cases, they've even put asthma as some of the key underlying causes. And specifically to look at Black women, for Black women, health disparities really persist across the spectrum. And the leading causes of death for Black women, African Americans and Black women, are heart disease, cancer. And so really we look at these rates, and Black women and Hispanic women, women of color, are heads of households in roughly 38% of their homes. They tend to be the most economically vulnerable. In fact, the fields that many women, Black women particularly, are in are the frontline workers, retail sales, and they're deemed the essential workers, which really made it hard for them, during the pandemic to be able to stay at home or work from home. So they were more susceptible to many of these uh, um, different disparities, health disparities. And contracting COVID. And so, to really go in depth about when we look at the population of Black women, we also take into account, other issues, such even in terms of the mental health. Are they at home taking care of an elderly or sick relatives? And then just generally, just to kind of give a picture of the COVID piece, also Black businesses, for example, really also were hit pretty hard. I mean, as all were, but for example, I mean, there were really limited protections and cash directives that were going to minority communities to help supplement, many of their job losses, had limited income. And so, for example, as we know, with many of the PPP loan, a lot of the funding, that ran out, and Congress had to go back and put dollars in just to make sure the funding would get to the folks that it was really intended to help. And so when we talk about the health disparities, I wanted to just kind of say this is the current state of COVID. These are the health disparities that impact African Americans, communities of color, Black and Brown communities. And then also there's another population within African Americans that were hit even harder, which will highlight Black women. But then when you look at, well, why are these health disparities here? And so you have to, we advocate to look through an equity lens. And and through that equity lens, you have to take into account not only those underlying health costs, but then also the social determinants of healthcare. And so the social determinants of health says, in addition to, there are other factors that influence these health disparities. There is, for example, your education, the neighborhood and environment you live in, your social community context, your economic stability. And I'll give an example here in Washington, D.C. So in Washington, D.C., wards 7 and 8, which are primarily African-American, there is only one grocery store in the entire ward 7 and 8. But if you go to more of another part of Washington, D.C., Ward 2 and 4, they tend to have, 5 and 6 grocery stores within a 1 mile radius. And so if you're talking to someone, for example, about obesity or diabetes, and you want to encourage a healthy lifestyle, but if you don't have access to a grocery store or opportunity to have healthy food, that's what we call a part of the social determinants of health. And so we're at Black Women's Health Imperative. One of the things we did early on in the pandemic was really get into the community and sort of educate the community. I mean, many of you may have heard early on, there was sort of a myth, African Americans, the Black community, they can't get COVID. And so we really wanted to get into the community and really become a trusted messenger to really provide trusted resources and reliable information. So we joined with a group, the National Coalition of 100 Black Women, and we launched an initiative called Our Health, Our Community. And it's really designed, again, to really raise the awareness about the pandemic, to also come up with solutions, when we do get on the other side of the pandemic, of how we can really build sort of resilient and healthy Black community. And so again, the initiative raised awareness of the impacts of inequity, of the social determinants, develop and advocate for practical and policy solutions that improve social determinants of health. And one of the things we're doing there is that we will be releasing a pandemic guide at the beginning of the year to provide to lawmakers and key stakeholders on just recommendations on how we believe that we can really build sustainable communities, but then also some of the nuances that may be helpful to Black women. And so we created a national discussion platform. We held about 6 virtual sessions, and we had an event. We had events for we had different geographics. So, for example, we did one national webinar. We always had a physician in the community. We made sure to have a key congressperson, an elected official. So we had a national webinar. Then we went and we had, and because of the constraints of COVID, but what we tried to do was go into the community. So, for example, in California, we had the member of Congress from California. We had physicians there, and we just talked about and tried to come up with solutions around and what was happening in California. We come up with solutions for that particular region. So, California, we did DC. We had the mayor of DC and also the health director in DC. We did one in North Carolina as well, and had the member of Congress from there. And then also we, then after we went to the different communities, we also wanted to know, like, what is the corporate response to the pandemic? And how can we work with the corporate community as well? And so we invited, pharmaceutical company, Kimberly Clark, which has Clorox. We also invited Google Health as well. And just to quickly, we really can't have a conversation about the pandemic without quickly mentioning just clinical trials and vaccine challenges. And the first part, we spent time again educating, providing resources to the community, talking about ways and coming up with policy solutions. And now everyone we have really now going to the distribution conversation, and then how will the vaccine actually be distributed? How will it be allocated? Black Women's Health Imperative, where I work, we also provided comments on where we thought the allocation should be. And so, just mention the Pfizer. You may have heard the news, the Pfizer clinical trial. They think they may be approved, to go into by the FDA to go into clinical trials, and they're saying now in a couple weeks, and also Moderna. Here, I'm sure you've heard of that one as well. And I think there's like a matter of months. It seems to change on a weekly basis, but we are closely monitoring both of these. And what we're doing now is we're partnering with several HBCU medical schools, the Black Nurses Association, and we're going out to really encourage minorities to participate in these clinical trials. And so, there is some vaccine hesitancy in the community. For good reason. A lot of minorities, remember the Tuskegee study, they sort of cite different reasons why they don't want to sort of be the first in line, but we are really encouraging that they participate in clinical trials because, one, we're the most, African Americans and Black and Brown, the most impacted. And so it's important to participate because, for example, different ethnicities, the drugs may metabolize differently in the body. And so it's important to see what those results are. So we're really encouraging, and again, trying to be those trusted messengers in the community, also trying to monitor informed consent, making sure that the patient is very aware of the effects that may happen in clinical trials. And then just quickly, this is a policy agenda that we released a couple weeks ago. And again, this is just a broad policy agenda about Black women and minority communities. There's specifically a COVID section in here, a clinical trial area as well. But the agenda really ranges from reproductive health. We filed a amicus brief in the court for the ACA. As you know, ACA is before the Supreme Court, but we filed a brief just really demonstrating how if we dismantle ACA, how women, and in particular Black women, would be impacted. And then there's also a HBCU area in here. And then just given some of the recent, the climate, we also added a social justice piece here as well. So really getting into, so I wanted to again set the stage with, you know, COVID, with the health disparities, you know, the current state of play now, how Black and Brown communities are impacted. And then, you know, to really help understand some of the barriers that in the social determinants of health that these communities face. And so, you know, telehealth is really has really been it's really revolutionizing the healthcare delivery. It offers opportunities to hard to reach populations, including low income, rural, Black, again, and Brown communities. The opportunity to telehealth for communities include reducing long wait times, long travel distances, and more personalized care. And so COVID-19 has revealed that the health disparities that disproportionately impact folks of color. But as we are moving towards a fast adoption of telehealth, we want to make sure that we do not sort of layer on top of the already existing disparities, the quote unquote digital divide. And so, I mean, as you know, these are just some of the things in terms of what telehealth services are used for, now during COVID. So screen patients who may have symptoms of COVID-19, refer them as appropriate, provide low risk urgent care for non-COVID-19 conditions, and and monitor clinical signs of certain chronic medical conditions. And so it's just really an opportunity. We see telehealth is sort of the silver lining during the pandemic, because it's the fast digital telehealth transformation that many have had to adopt because of the pandemic. So we see telehealth is not only really a solution to improve access to healthcare, but it should not fully replace it should not fully replace in-person care for patients, but it can definitely be complementary. And so during the public health emergency, Congress in March, so there are barriers to telehealth. However, Congress in March approved a new set of rules or federal requirements to allow local hospitals and health systems to serve patients via telehealth during COVID. Many of those services will most likely become the standard that we hope, but they will expire. And so, as we'll get into later in the presentation, we can talk about some of the recommendations in order to make some of these relaxing, the flexibility that they relax some of the rules that in making these different requirements to relax them so that telehealth can be more readily adopted. But in terms of digital divide, according to FCC, at least 25 million people, 19 million who live in rural areas lack broadband internet access. Lack of broadband adoption is greater among Black, Hispanic, and lower income households. 4 in 10 Americans making less than $30,000 a year lack either a home broadband connection or a computer, and nearly 60% without broadband at home cite the cost of subscription as the leading barrier to adoption. But there is more than $22 billion in subsidies and grants that have been provided to carriers to sustain, extend, and improve broadband in rural America. And just some equitable considerations as we were talking about telehealth is that it should be implemented in sort of a culturally competent way. And during the pandemic, we should take into account. So we talked about some of the barriers or some of the health disparities that Black and Brown communities have. But then you're also layering, as we adopt the telehealth, you're also layering on top of that individuals who may not have access to a computer or, asking students to work remotely or online who may not have, Wi-Fi. And also if there's a, if you want to, these folks, underserved communities, for example, if, for example, they want their patient appointment, they may live in a crowded or multi-generational environment where they can't go to a private area to have a telehealth visit. And so those things also have to be taken into account. And so, as mentioned, there were 4 pieces of legislation that Congress enacted around to really provide some relief for COVID-19. And the relief was not all, there were 4 pieces, but in particular, the Coronavirus Aid, Relief, and Economic Security Act, and we call it the CARES Act for short, was really the one that provided dollars for telehealth. And so there's $2 trillion in there. It included, the overall bill was $2 trillion, but it included $200 million for the FCC to expand telehealth services across the country. There's also $100 million in the bill for the Universal Service Fund, where they created a pilot, 3-year pilot program called Connected Care Pilot Program, which is used to subsidize internet connectivity for healthcare providers. Also on the Hill, there's telehealth legislation. We're waiting now. We're hoping there will be another relief bill, but there's legislation has been introduced that would, for FY 2021 supplemental, FY 2020 supplemental appropriation to actually increase our fund to the 200 million, additional 200 million. Also, lawmakers have really kept their word and saying that we really want to add more funding to the program, to the telehealth program. So there's a lot of activity that's happening on the Hill. There's the Telehealth Expansion Act out there. There's the Keep Telehealth Options Act. So definitely many members have introduced legislation. And then just to sort of talk about some of the reimbursement barriers to telehealth adoption. Really one of the most impactful barriers to the implementation of telehealth has been whether the amount allowed for payment is enough to create an economic incentive for doctors and for system integrators and device manufacturers to develop the technology. And in addition, there have also been, in terms of licensure is also another issue as well in terms of barrier to telehealth adoption. Many of the healthcare workers, as you know, have to be licensed. And, for example, if you are in Maryland and you wanted services in, Virginia, some of the early barriers have been around, having the license, being able to provide those services. We also incompatible electronic health records, and then also, again, as we mentioned earlier, gaps in rural broadband. And so some of the legal considerations include cybersecurity, HIPAA compliance. And this is really around, protecting the patient's information. But this is the area as well where Congress relaxed some of the previous restrictions that were in place that were really barriers to the adoption of telehealth. Also, we get into, as we mentioned, licensure. Also, you get into informed consent, like what constitutes, the patient agreeing to the service via telehealth. And then, as we mentioned, we talk about the privacy issues. And so really the primary security risk really stems from the unauthorized access to data during collection, transmission, or storage. Any transfer, offers potentially a security breach. And then again, just to reiterate, telehealth apps that collect data directly from the consumer are not covered by HIPAA, But as providers transition from various technologies, the data loses HIPAA protection. And this is just this is a study that our the CEO of Black Women's Health Imperative was one of the co-authors. And this is just a new area, but it's another area to show how equity is really in play here throughout, whether it's and we really didn't get into whether digital health versus telemedicine, AI, but here this is it was a study and. It shows racial bias in terms of the electronic health record system. And so, for example, at this particular clinic, the Black and Brown patients, it would look at the probability of whether patients would actually show up for their appointments. And where if the probability, based on the probability of the rating, they would double book the patients who were less likely to show up for their appointments. And so this study really it found another way, another algorithm to really standardize the racial bias that we found in medical appointment scheduling. And so and then kind of going on as well to some of the policy recommendations beyond COVID. As mentioned, Congress also, they relaxed some of the telehealth requirements. And so these are just some of the recommendations that we're putting forth as ways beyond COVID that we can make permanent some of those telehealth provisions. So here's data on COVID-19. Telehealth administration and programs should be collected and analyzed. Regulatory flexibility should be built into telehealth to accommodate the range of use cases. Telehealth services should be utilized for primary care to reduce service redundancies. Innovation in privacy and data security and telehealth services should be the norm. And then again, really working to bridge that digital divide. And so the telehealth service should be available to the medically unserved as well. And so why is this important? Everything I've talked about today, and how, can viewing through the equity lens ultimately lead to health disparities and saving, really in saving dollars for our healthcare system. And so we really think it's important to, as you look at technology, as we look at the COVID pandemic, and we look at the underlying health disparities, how do we really take into account, and looking from an equity perspective, we can then come up with ways that are nuanced, that's not a one-size-fit-all solutions long term to make the technology that was relaxed during the Congress's relaxed, but then also closer to solving or closing the health disparities gap. And I don't think there are any questions.
Thank you very much, Tammy. That was terrific. We have a few questions. I'm going to ask the first one. And that is, so in the CARES Act, the $200 million for telemedicine, do we know how much of that was targeted at Black and Brown populations?
We don't know how much was targeted. I mean, we don't know how much was targeted to Black and Brown communities. I could definitely find that out for you. I can say that, there were several that said they did not receive it, but data-wise, statistically, we don't know how much they actually received as of yet.
But was there in the CARES Act in this allocation a sort of imperative to remedy the health disparities problem, or was it was it just kind of a general grant and notwithstanding?
It was a general grant. It was really for providers. So it was a general grant. It wasn't necessarily indirectly you can say yes to remedy the health disparities and to sort of address, help them get to speed on some of the technology, but there wasn't a specific designation to say to solve health disparities.
And just to follow up on that, do any of the proposed bills on telehealth that you mentioned, do any of them focus on the Black and Brown community in particular?
So there are some that focus on the Black and Brown community. There are several groups that are putting forth that. So on the House Energy and Commerce Committee, Representative Robin Kelly and Representative Yvette Clark, Robin Kelly from Illinois, Yvette Clark from New York, they are the co-chairs of the Health Disparities Working Group. And that is one of the things that they, for the Energy and Commerce, also regulates the legislation, the telehealth legislation. And so that is one of the key areas that they are examining, and we'll try to fight to make sure that's included.
Okay. Sharona, you're muted.
Yes. We have a question that was submitted, and that is, has there been any research on whether COVID can be passed on through the womb? In other words, have they found any children that have actually been born with COVID?
I don't, not to my knowledge, but I'm not sure about that. So I have the answer to that. I mean, we have focused on in terms of, you know, pregnant women and COVID, and how, you know, when they go to the physician, when they go to the ERs, and making sure they have certain protections. But I don't want to give the answer, and I'm not quite sure about that answer.
Aside from remedying the telehealth disparities gap, if you will, what do you view as the other most important steps that need to be made in order to respond to the health disparities problem with COVID?
Well, so I mean, the telehealth piece is happening very fast, and so again, you know, there's several reasons why there is a digital divide, and so providing some infrastructure support to address that. So, you know, as you know, we all heard Dr. Fauci said that health disparities has definitely been with us. It's just shining, COVID is just shining a bright light on those disparities. And so, you know, for health, I mean, it's not new for folks who are in the healthcare space, but it has brought awareness. And so I think this is an opportunity to really show where we can put dollars to sort of to address some of those disparities. I mean, so you can go one by one. I mean, for example, diabetes or obesity, you know, it could be pre-diabetes prevention, it could be lifestyle changes, but you could also utilize telehealth as well if we have the infrastructure and the there to make sure these folks or these communities have access to it.
Is there any concern that telehealth will actually exacerbate health disparities? In other words, that people who are disadvantaged will actually be given care only through telehealth, that doctors will decide, oh, you're not being you're on Medicaid or whatever, I'm just going to do telehealth visits with you?
Well, so I guess there's two questions. So the concern is that telehealth could exacerbate the health disparities, again, if it's not applied in the right way. But in terms of, I have not heard in terms of Medicaid whether they'll say only telehealth. I mean, so for example, many of these folks, you know, in the rural areas, I mean, they don't have a way to get to some of their follow-up. They'll go to the doctor, but then they may not go back for their follow-up appointment. And so, particularly, for example, for breast cancer, Black women would go in and get a 2D mammogram, but then they'll be asked to come back for a 3D mammogram. And as you know, Black women do not get breast cancer, more so than say they're white women. However, they tend to have higher mortality rates. And so one of the pieces that we looked at is that, I mean, one of the areas is that they don't necessarily go back for the follow-up appointments, or there may be a copay. So I don't think it would be just only telehealth. I haven't heard that concern, but I have heard the concern of that the way you layer telehealth on top of health disparities may be an issue.
Okay, so are there particular things that folks can do to try to steer funding to close the digital divide? I mean, write their, you know, members of Congress. What would you recommend?
Yes, they can write their members of Congress. if many of you are lawyers, you can join your bar associations. I mean, many of them have government relations sort of working groups or and advocate. You can write letters to members of your physicians. I mean, they are. I know the American Medical Association, the National Medical Association, a lot of the groups. I mean, like Health Imperative, we're steadily always trying to weigh in and provide comment letters to many on many of these issues. But the I would say the easiest part of things is yes, reach out to your member of Congress and really talk to them about these issues and advocate.
So are you concerned that the fact that a lot of these vaccines require 2 doses is going to be very difficult for disadvantaged communities? Because maybe they can get there once, but the fact that in 3 weeks or whatever they have to go again is going to be a real barrier to getting them fully immune.
Yes, and so we are looking at the vaccine pieces and also talk in meetings where many of these Pfizer and Moderna, they and previously AstraZeneca, where they are presenting to many of the minority groups and talking to them about many of these things that could be barriers. I mean, from the vaccine hesitancy to, will you be able to go back to do, or what are some of the incentives to provide so that these folks would come back, say, for the second round, the booster. So yes, those are, but I will say that there's several groups that have formed and everyone is really trying to work collaboratively and coming to the table.
So in addition to trying to enroll a substantial number of minority participants in the vaccine trials, is there anything else that should be done to respond to vaccine hesitancy on in Black and Brown communities?
Yeah, so yes, so recently there's a news article where even, for example, the president of Dillard University and Xavier University, they are actually participating in, which are historically Black colleges, they're actually participating in the vaccine trials. So the medical community, for example, the medical schools are all a part of the conversation as well. The president of Meharry is on the FDA's vaccine advisory group. And so we know that it's going to take not just one stakeholder, but that all the stakeholders really have to go out into the community. Again, it's trusted messengers, and with some of the pastors, the faith-based community, but most recently, some of the HBCU presidents are saying, "Hey, we are actually participating in this trial, and we think that it is safe." And so it's going to really take, I think, a lot of trusted messengers. I mean, I know several people who say that I don't want to be the first to get in line for the vaccine, but we are really encouraging that it's really important for. Really, generally, it's very important for minorities to participate in clinical trials.
And how about the issue of storage? Some of these vaccines, the Pfizer vaccine has to be stored at an incredibly low temperature. Are Black and Brown communities going to have the ability to handle those kinds of storage requirements and the sensitivity of these vaccines?
Some will, obviously, but I think that is definitely a valid, that's definitely a valid concern. And it'd be interested to know, how, just generally how for most folks, how the companies are going to sort of address or provide incentives or provide some help in cases where folks can't do that.
So on telehealth, but not so much on COVID, are there racial disparities in reproductive health that an expansion of access to telehealth could be responsive to?
So it's definitely for reproductive health. So for reproductive health, I mean, just if you talk maternal, for example, maternal mortality, we know that impacts Black women. They die in maternal from maternal mortality they're 3 to 4 more times likely to die in childbirth. Then we also know that Medicaid, for example, pays for about 48, 47% of reproductive health and births. And so in terms of telehealth, um, just getting your prenatal visits, just getting women to show up to go to their visits. I mean, that's an aspect as well. Um, uh, in terms of other reproductive health appointments, we talked about breast cancer, but on the reproductive health side, you can say cervical cancer. So, for example, in Alabama, which has the highest rate of Black women who die from cervical cancer, and as we know, I mean, cervical cancer is is totally preventable, and so no one in the United States should be dying from it. But when we partnered with a group called the Human Rights Watch, I mean, one of the main reasons was that we saw again was because women did not go to their follow-up appointments, or they just didn't go to some of their routine appointments. And so from cervical cancer, from prenatal, your maternal appointments, telehealth can definitely play a role in reproductive health.
So you mentioned Medicaid payment for reproductive health services, and following up on that, is there a concern that the cost of the COVID vaccines will be prohibitive for poor members of the community? And or is it pretty much understood that there will be steps taken to prevent that?
I think that there will be steps taken to make the vaccine accessible to folks. Um, I don't know. I mean, so yes, I don't know specifically what those would be, but I think there will be steps definitely taken.
Okay,
I have another one, Sharona, if you want
go
to
ahead,
take it.
go ahead.
Yeah, so we have a question about asking if you could tell us more about the equity problem with virtual health records.
So the health records piece is that so your health records are not standard across in different states, and so that's just one barrier. Not necessarily in COVID, just period in terms of a barrier um, um, to telehealth. It's just really a standardized um, health records, but then you also get into again the privacy issues just in terms of the transmission of the information.
So, we have these statistics that tell us that the US is really the worst country right now in terms of COVID, but we also have better testing capacity, presumably. So are the statistics skewed? Is it just that we're doing a whole lot more testing and better testing than other countries?
Um, so we have heard that argument. I sort of disagree. I think that in terms of at least what we're recommending in our pandemic guide is definitely a more restrictive um, recommendations in terms of how to stay safe and to protect yourself. And so a lot of it is just the wearing your mask. The small gatherings are the ones that get folks into trouble. But so do we think it's just more testing? Not, we don't go for the premise it's just more testing. We think it's more or less just in way the response in terms of how we think it's more the response to COVID-19 in terms of the stay at home, et cetera.
So from your perspective on the Hill, or in Washington, I should say, is anything happening to address the food desert problem in terms of federal activity, federal legislation?
So there's several different grants that are out there. I mean, for example, Black Women's Health Imperative, we are actually working on a food desert, a project in Mississippi to really try to help provide healthy food to vulnerable populations. So there's funding out there. I think that, but it's constantly evolving. I mean, I know that, for example, the food deserts don't necessarily have to be in rural areas. They can also be in inner cities. So, for example, in DC, even the Walgreens is now in Washington becoming sort of like a grocery store, and it's sort of to address some of the food desert issues. So that's really of a collaborative effort. But we are, Black Women's Health Imperative, we are working on a project specifically around the whole food desert issue.
So are there specific types of hospitals or other healthcare providers that are doing better than others at meeting the needs of minority communities? And is there anything we can learn from particular healthcare providers or particular regions?
There's studies that say that Black patients do better with Black physicians that look like them. And so, one of the things, and the health outcomes seem to be better. And so one of the things we are working on is an implicit bias. You know, where should we've advocated to Congress, to include, implicit bias trainings, for example, and even the medical school curriculums. How do we sort of address that? When we talk about the maternal mortality issue, that sort of even gets into, to your question, whether some providers do better than other providers. When Black women tend to go into the doctor, their pain may not be taken as seriously, or we've heard sickle cell patients, when they are in extreme pain, when they go into the doctor, their pain may not be taken as seriously. It may be seen as like drug seekers. But on the maternal mortality side, so we've had one of the biggest celebrities, Serena Williams, who, she said that if she didn't really advocate for herself and push that, her outcome with her and during her pregnancy could have been different. So I think there are lessons that we can kind of take from different provider scenarios.
So we have a data question, and that is, do we know the relative contribution of comorbidities to the disparate effect of COVID on minority populations, as opposed to more general health disparities, such as other determinants of health and so on? Does that make sense?
Not, can you repeat? No. Well, are you saying that, do we know what the numbers are in terms of how many minorities or Black or brown are dying from COVID versus?
Have we been able to quantify the impact of of comorbidities, like diabetes and hypertension and so on, in the Black and brown community, in terms of the effect on COVID, uh, uh, um,
Yes.
cases?
So, as we know, I mean, there are underlying conditions that disproportionately impact. There are underlying conditions that are correlated with more severe complications with COVID, which are the ones sort of named: diabetes, hypertension, obesity. And so of those, minorities are disproportionately, they have higher rates, higher numbers on the health disparity side. So, so I think I'm answering your question, but yes, I mean, we do know that the health disparities that are the underlying health conditions that are correlated with severe complications or COVID, that they are chronic diseases that disproportionately also impact minorities, and particularly African Americans.
So we know that we have a prevalence of preterm births in communities of color, and that leads to higher rates of infant mortality. Are you at all concerned that COVID will make this worse, or are there steps being taken to address those kinds of problems at the same time that we are fighting COVID?
So as mentioned, we're monitoring pregnant women, sort of what happens with them. We are starting to even collect sort of patient stories. We, for example, we've early on, Black women were in the emergency rooms longer, had longer wait times because of the COVID was taking place, but making sure they're in safe environments. So so yes, we are monitoring that, but uh, there's definitely, the groups are definitely looking at how do we make sure women are protected, pregnant women generally are protected during this pandemic.
We are just about at the end of our time. You've done a remarkable job of giving us your opening talk and also answering almost 20 questions. So thank you so much. I'm going to uh, post a slide which will give CLE information in just a moment. And I'm going to also read the activity code for those of you who are attending by phone rather than visually. But I'd like to, on behalf of Case Western Reserve University School of Law, thank you so much, Tammy, for your excellent thoughts, and I hope that your efforts meet with great success.
Thank you.